In this presentation, I'm going to discuss orthotic prescription in relation to tibialis posterior dysfunction. So the origin of Peter's pain is located in the midfoot, and his pain is palpable on the medial midfoot region of the medial cuneiform and also at the base of the first metatarsal, which is essentially where the tibialis posterior tendon inserts. Upon muscle testing, he also experienced moderate pain against resistance on inversion. So this was also indicative that the tibialis posterior tendon is most likely responsible for his pain. So the function of the tibialis posterior tendon is to invert and plantarflex the foot and ankle, and it also plays a vital role in stabilizing the medial arch of the foot. So if we take a look at the image to the right, we can see a medially deviated subtalar joint axis. So this axis would be similar to that of Peter's. And if we look on the medial side of the axis right here, we can see that the surface area available for applying an orthotic force is quite minimal. However, if we look towards the rear foot, the surface area available here is slightly larger. So this is where we would want to apply our external orthotic force. So for the orthotic type, we selected a traditional orthotic type. Because Peter's foot is highly pronated, it can potentially slide off the orthotic on the lateral side. So a traditional orthotic type provides a deep heel cut with both medial and lateral support. So this will prevent his foot from sliding off the orthotic, and it will also provide adequate support to his rear foot. So under the arch fill option, I selected inverted standard. So I thought an inverted orthotic would be suitable for Peter's case as it's a rear foot device and provides rear foot correction, and the high point is located under the sustentaculum tali. So therefore we would be able to apply the greatest supinator force within the rear foot. I chose this over a midfoot device because Peter is already experiencing pain within the medial longitudinal arch of his foot, and I wanted to avoid further aggravating and irritating his pain. For the arch fill, a 90% arch fill was selected, and this was to prevent sudden change in force, as mentioned previously, to avoid irritating and further causing pain within this medial arch. And another reason I chose a standard arch fill was because he has limited dorsiflexion within his ankle of 50 millimeters. Therefore, a standard arch fill would be less aggressive and would make sure that his ankle joint range of motion isn't further restricted. So under the cast correction option, I chose a 20-degree rear foot moderate correction for Peter, as his foot is highly pronated, and he also has a hypermobile foot type, so he's more likely to tolerate an increased force well as opposed to someone with a rigid foot type. However, it should be noted that a 20-degree rear foot correction would also cause an increase in arch height of the orthotic of 10 millimeters, which I thought in Peter's case would further help support his medial longitudinal arch. So this is why a 20-degree moderate correction was selected. So for the shell material, I chose polypropylene 3.5 millimeters semi-rigid. So polypropylene provides solid support for the foot, and the reason I chose it is because it's important that the orthotic does not compress upon weight bearing. So for that reason, it's important to consider the patient's weight, because if the orthotic does compress, it ultimately defeats the purpose and it's unable to carry out its function because it's not able to provide and apply an adequate force to the foot. So it's important to consider these factors when selecting the shell material. And in Peter's case, he would be wearing his orthoses daily for work, which involves a significant amount of physical activity. So that's another reason I thought choosing polypropylene, which is a quite solid material, would be appropriate for Peter's case. So now I'm going to talk about adding a medial heel scarf to the orthoses. So if we take a look at this image here, we can see a posterior view of the tibia, the talus, and also the subtalar joint axis right here. And we can also see the center of orthotic force being applied through the foot, which is represented by this vertical dotted line here. Now on the image on the right, we can see that by simply adding a medial heel skive, that the center of orthotic force is actually shifted medial to the subtalar joint axis. So what this does is it ultimately helps apply a greater supinatory force around that axis. So Adding a medial heel skyve could be a feasible option in Peter's case if we do require that extra supinatory force to be added on the medial side of his subtalar joint axis. And in that case, a 4mm skyve would be most likely recommended. Another orthotic modification that can be added is known as a medial phalange. So a medial phalange can be used for extrapronatory control. It provides containment within the medial arch and around the first ray and the talonavicular region. It also provides a larger surface area medial to the subtalar joint axis, which will allow for a greater supinatory force to be applied within this region. However, in patients with flat feet such as Peter, it's important to look for talonavicular bulge. As he's highly pronated, he's likely to have talonavicular bulge, and in that case, applying a medial phalange might actually irritate this talonavicular region, causing him discomfort and pain. However, this can be accommodated for by actually creating a pocket in this area within the medial phalange and adding some padding within the pocket. However, although the medial phalange is useful in some cases, most adults can't actually tolerate the excessive stiffness and control that comes with a medial phalange. Therefore, for that reason, it's most commonly used in children, and I don't think in this case it would be quite suitable in Peter's case, as it would add a significant amount of bulk to the orthotic and make it significantly more aggressive. So it is there as an option, but I don't think it would be quite essential in this case. A standard shell with a full heel stabilizer was selected. So the full heel stabilizer will make sure that the orthotic doesn't move around too much in the shoe, and also make sure that there is no rocking of the orthotic while it's being worn. So a Standard Plus leather top cover was selected for the orthoses. Standard Plus comes with an underlying pour-on base, which allows for extra cushioning, and leather is suitable as a top cover choice due to its high tensile strength and resistance to tearing. It's also breathable and a good insulator, which is suitable for Peter as he would be wearing the orthoses daily for work. So that's the reason a leather top cover was selected for the orthoses. Okay, so now I'm going to talk about how the orthotic will actually work and function. So if we take a look at this image to the right, we can see a medially deviated subtalar joint axis here. And on the medial side of this axis towards the rear foot, we can see where our orthotic force would be applied. So applying an orthotic force medial to the subtalar joint axis over here will cause the weight that was acting lateral to this subtalar joint axis here to be redistributed and to essentially shift to the medial side of this axis. So what this would do is it would create an increase in the supinatory moment acting on the medial side of the subtalar joint axis, and for this reason it would decrease the total pronatory moment acting on the lateral side of the subtalar joint axis over here. In addition, it will also decrease the internal supinatory contractile force that needs to be generated by tibialis posterior in order to invert and plantar flex the ankle. So by decreasing the tendon's tensile force, it would also allow the tendon to repair, and it would allow the tendon to heal itself, which would ultimately reduce the symptoms associated with tibialis posterior dysfunction. Okay, so now I'm going to talk about how the orthoses will function in terms of stabilising the medial longitudinal arch of the foot. So if we take a look at this image in the top right corner here, we can see that upon weight bearing we get a vertical loading force coming down through the tibia to the superior aspect of the talus. So this vertical force places excess pressure to the superior aspect of the talus here, which ultimately causes the talus to plantar flex. In turn, this also increases the tensile force exerted by the Achilles tendon, which opposes the vertical loading force through the tibia. Now, when we combine this with the ground reaction force acting on the rear foot, what we ultimately get is a rear foot plantar flexion moment, so the rear foot plantar flexes. Now, if we take a look at the forefoot, we can see the ground reaction force acting on the forefoot here, which essentially causes the forefoot to dorsiflex. So when we combine rear foot plantar flexion with forefoot dorsiflexion, what we essentially get is a collapsed medial longitudinal arch. Now, if we take a look at the image below, we can see when an external orthotic force is applied to the medial longitudinal arch, this causes the rear foot to dorsiflex, and it causes the forefoot to plantarflex. So for this reason, it stabilizes the medial longitudinal arch and recreates this arch. So it does this by increasing the surface area between the orthotic and the medial longitudinal arch, and what this ultimately results is in a redistribution of plantar pressures from the rear foot and the forefoot to the midfoot area. And we also know in Peter's case that he has restricted ankle dorsiflexion, which could be due to his collapsed medial longitudinal arch, which would ultimately cause tightening of his gastrocsoleus complex and therefore restricted dorsiflexion. So by providing this medial arch support, we could also potentially increase his amount of ankle dorsiflexion. Some alternative interventions that we can use to reduce the stress placed on the tibialis posterior tendon include weight loss. So recent studies have suggested that obesity can predispose individuals to abnormal pronation by causing a medial shift in weight bearing. So as pronation is also linked to tibialis posterior dysfunction, it can be for that reason, it can be suggested that weight loss may be an effective recommendation for actually reducing the stress placed on the tibialis posterior tendon and thus allowing it to heal. Another intervention would be rest and immobilization. So that can include reducing activity, reducing physical activity, which would reduce the stress placed on the tendon and allow it to heal. It can also include wearing a removable boot or below knee cast for a period of 2 to 6 weeks, and ultimately that would also reduce stress and allow healing of the tendon. So some interventions that can be implemented to increase the capacity of the tendon to tolerate load include footwear. So wearing laced shoes, boots, and running shoes with motion control can all help stabilize the foot posture. And also wearing shoes with a supportive sole can aid in shock absorption, which may in turn decrease the amount of stress placed on the tendon. Alternative interventions also include strengthening exercises, so doing single leg heel raises and doing resistant band inversion exercises can all help strengthen the tibialis posterior tendon, which as a result would increase the capacity of the tendon to tolerate load. So this is my completed footwork prescription form, and all the variables discussed in this presentation have been filled out within this form also.